All right, so this chapter is going to cover depressants and inhalants. Most people have a good idea of the effects of alcohol, and these drugs have effects that are generally similar. Depending on the dose and the situation, people may experience relaxation, exhilaration, inebriation, or drowsiness, or they may become stuporous and uncoordinated. These CNS depressants are considered as a class because of the common effects. Beginning with the introduction of the barbiturates in the early 1900s, a series of prescription drugs have been marketed for two medical purposes. Many people have used low doses of these drugs to reduce anxiety and to keep them calm and relaxed. When prescription drugs are used in the way that they are known as sedatives, um, current examples of popular sedatives include Xanax and Ativan or lorazepam, both members of the chemical class the benzos. When these medications are used as sleeping pills, they are known as hypnotics. Before barbiturates in the early 1900s, a Chicago bartender named Mickey Finn became infamous when he was prosecuted for adding chloral hydrate to the drinks of some of his customers, after which they would become incapacitated and be robbed by one of his house girls. First synthesized in 1832, chloral hydrate was not used clinically until about 1870. It is rapidly metabolized to trichlorothianol, which is an active hypnotic agent. When taken orally, chloral hydrate has a short onset period, 30 minutes, and 1 to 2 grams induce sleep in less than an hour. Chloral hydrate abuse is a tough way to go. It's gastric, irritant, and repeated use can cause considerable stomach upset. Paraldehyde was synthesized in 1829 and introduced clinically in 1882. Paraldehyde would probably be in great use today because of its effectiveness as a CNS depressant with little respiratory depression and a wide safety margin, except for one characteristic. It has an extremely noxious taste and an odor that permeates the breath of the user. First introduced in 1903, the barbiturates became so important that eventually over 2,500 different examples of this chemical class were synthesized and quite a few were marketed. Examples of once popular barbiturates include um, phenobarbital, amorbarbital, and secobarbital. The barbiturates are grouped according to their duration of action, how long the drug's effects last, which also happens to correspond with how quickly they act after being taken by mouth, which is the time of onset. The short-acting barbiturates begin to produce effects in as little as 15 minutes and have effects lasting only 2 or 3 hours, whereas the long-acting drugs may take an hour to produce effects, but they may last for 8 hours or more. Although the majority of people who took these medications did so without harm, the barbiturates were associated with overdose deaths, both accidental and intentional. As with other CNS depressants, the cause of death is typically respiratory depression, breathing slows, and then eventually stops. And in great many cases, this is due to the combined effects of alcohol and a depressant drug. Meprobamate was patented in 1952 and was believed to be a new and unique type of CNS depressant. The FDA approved its use in 1955 and it quickly became widely prescribed, based partly on a successful publicity campaign and partly on physicians' concerns about prescribing barbiturates. Methaqualone was synthesized in India and found to have sedative properties. Germany introduced methaqualone as an over the counter or non prescription drug in 1960, had its first reported suicide in 1962, and discovered that 10 to 20% of the drug overdoses in the early 60s also involved this drug. Apparently, no one in the United States was paying much attention to these problems in other countries because in 1965, after 3 years of testing, Quaalude and Sapor, brand names for methqualone, were introduced in the U.S. as prescription drugs with a package insert that read addiction potential not established. So in the early 1970s in this country, the ludes and the Saporas were familiar terms in the drug culture and in the drug treatment centers. Physicians were overprescribing a hypnotic drug that they believed to be safer than the barbiturates. In 1973, 8 years after it was introduced in this country, 4 years after the American scientists began saying it produced addiction, and 11 years after the first suicide, methqualone was put on Schedule 2. And by 1985, methqualone was no longer available as a prescription drug and is now listed on Schedule 1. The first of the benzodiazepines were chlorozepatoxide, which was marketed under the trade name Librium, possibly because it liberates one from anxieties. But Librium was marketed in the 1960s as a more selective anti-anxiety agent that produced less drowsiness than the barbiturates and had a much larger safety margin before overdose death occurs in animals. Chlorodiazepoxide produced a few problems with either withdrawal symptoms or overdoses. Diazepam has a more rapid onset, but because of slow metabolism and the presence of active metabolites, it also has a long duration of action. The first, or the Rohypnol, which is a benzodiazepine sold as a hypnotic in many countries around the world, but not in the U.S., hit the news when reports surfaced of its being put into the drinks of unsuspecting women by their dates. The combination of Rohypnol and alcohol was reputed to produce a profound intoxication during which the woman would be highly suggestible and unable to remember what happened to her. In reality, Rohypnol effects are not much different from the effects of other benzodiazepines when combined with alcohol, but popular folklore quickly established it as a date rape drug. And so in 1997, the drug's manufacturer changed the formulation of the pill so that when it dissolves in a drink, it produces a characteristic color. So, non benzohypnotics, the most recent additions to the class of depressant drugs, do not have the chemical structures of the benzos, but have similar effects. Ambien was introduced in 1993, followed later by Sonata and Lunesta. Ambien quickly became the most widely prescribed hypnotic drug in the market. It has a rapid onset and short duration of action, similar to the short-acting barbiturates that were once so popular. An important key to understanding the effects of these sedative hypnotic agents was found in 1977 when it was reported that the diazepam molecules had a high affinity for specific receptor sites in brain tissue. Other benzodiazepines types of sedatives also bound to these receptors, and the binding affinities of these various drugs correlated with their behavioral potencies in humans and other animals. It was soon noticed that the benzos receptors were always near receptors for the amino acid neurotransmitter, which is GABA. It now appears that when benzos and their non-benzos cousins bind to their receptor site, they enhance the normally inhibitory effects of GABA on its receptors. The anxiolytics, the four benzos are listed among the top 100 most commonly prescribed medications in the U.S., which is Xanax, Ativan, Klonopin, and Valium. They are all relatively long-lasting drugs used primarily as anxiolytics to reduce anxiety. If anxieties produce dysfunctional behavior and these drugs can reduce anxieties, then the drugs will be useful in reducing the dysfunctional behavior. Although this approach seems logical, in reality, not all of these conditions respond well to anti anxiety drugs. Hypnotic drug therapy is based on the idea of taking a large dose to help a person get to sleep more quickly. Insomnia, which is a term used to include several symptoms like trouble falling asleep, trouble staying asleep, or waking up too early. In an analysis of a large national health survey in the United States among adults aged 20 to 39, almost 17% of women and about 9% of men reported one or more of these concerns. Previous research has shown that most people who are concerned about insomnia do not take prescription hypnotic drugs, and there are effective non medical ways of dealing with insomnia. However, there's a large enough market for these drugs to encourage new drug development and quite a bit of television advertising. After 1976, the benzos displaced the barbiturates in the sleeping pill market, and by the early 1990s, Halcyon sales had reached 100 million per year in the US, excuse me, and 250 million worldwide. However, there was concerns raised about the safety of the drug, and the Upjohn, the drug's manufacturer, was sued by a woman who claimed the drug made her so agitated and paranoid that she had killed her own mother. That case was settled out of court, but it brought attention to the drug and to other claims that it produced an unusual number of adverse psychiatric reactions in patients. Both the barbiturates and the benzos are widely used for the control of epileptic seizures or epilepsy. Anticonvulsant medications are given chronically, so tolerance tends to develop. Uh, the dose should be kept high enough to control the seizures without producing undesirable drowsiness, and abrupt withdrawal of these drugs is likely to lead to seizures, so any medication changes should be done carefully and with warning and under doctor care. Most people who have used either barbiturates or benzos have not developed a substance use disorder. However, it was clear with the barbiturates that some individuals do develop problems related to the frequent use of large doses. Again, the short-acting barbiturates seem to be the culprits. Animals, given the opportunity to press a lever that delivers intravenous barbiturates, will do so, and the short-acting barbiturates work best for this. Animals will also self-inject several of the benzos, but at lower rates than with the short-acting barbiturates. When human drug users were allowed an opportunity to work for oral doses of barbiturates or benzos on a hospital ward, they developed regular patterns of working for the drugs. These experiments indicate that these sedative drugs can serve as reinforcers of behavior, but that the short-acting barbiturates are probably more likely to produce more robust reinforcing effects than any of the benzos that are currently on the market. A characteristic withdrawal syndrome can occur after chronic use of large enough doses of the sedative hypnotic drugs. This syndrome is different from the opioid withdrawal syndrome and quite similar to the alcohol withdrawal syndrome. After chronic use of benzos, common side effects include anxiety, impaired concentration and memory, insomnia, nightmares, muscle cramps, increased sensitivity to touch and to light, and many more. More severe withdrawal symptoms occur after abrupt withdrawal from chronic use of larger doses and may include delirium, delusions, convulsions, which may lead to death, and severe depression. Drug treatment is often used, and a general rule is to use a long acting drug given in divided doses until the withdrawal symptoms are controlled. Typically, one of the benzos is used during detoxification from any of the CNS depressants, although one of the specific anticonvulsants may also be used effectively. The major area of concern with these depressant drugs are the behavioral and physiological problems encountered when high doses of the drug are present in the body, or acute toxicity, we call it. Behaviorally, all these drugs are capable of producing alcohol like intoxication with impaired judgment and coordination. Obviously, such an impaired state vastly multiplies the dangers involved in driving and other activities. And the effects of these drugs combined with alcohol are additive, so the danger is increased. On the physiological side, the major concern is the tendency for these drugs to depress the respiration rate. And again, the combination of these depressants and alcohol can be quite dangerous. Historically, two groups have been more likely than others to develop problematic use patterns. One is older adults who obtain the drug on a prescription, either for daytime sedative or use as a sleeping pill. Through repeated use, tolerance develops and the dose is increased. The other group tends to be younger and consists of people who obtain these drugs to alter their consciousness. Sedatives in pill form might be taken from the home medicine cabinet, or the drugs might be purchased on the streets. Gasoline, glue, paint, lighter fluids, spray cans, almost anything like nail polish, liquid paper, these all contain volatile solvents that, when inhaled, can have effects that are similar in an overall way to those of the depressants. High dose exposure to these fumes make users intoxicated, often slurring their speech and causing them to have trouble walking a straight line as if they were drunk on alcohol. Gaseous anesthetics, one of the oldest nitrous oxides, was first used in the early 1800s and quite early acquired the popular name laughing gas because of the hilarity exhibited by some of its users. Nitrous oxide is still used for light anesthesia, especially by dentists. Nitrous oxide is also found as a propellant in whipping cream containers and is sold in small bottles or whippets for use in home whipping cream dispensers. Nitrates, or amyl nitrite, was the first introduced into medicine in the mid 1800s as a treatment for chest pain. Amyl nitrate is still used in emergency medicine as a treatment for cyanide poisoning, and for much of the 20th century, it was sold in small glass vials that could be snapped in half or crushed to release the vapors under the nose. During the 1960s, there was some recreational use of these poppers. The increased blood flow created a sense of warmth, and increased blood flow to the sexual organs might have accounted for the street lore that nitrates can enhance sexual pleasure. Although these glass vial poppers are much less available these days, the term poppers remains as the most common street name for illicitly sold nitrates. The modern era of solvent abuse, or at least widely publicized solvent abuse, can be traced to a 1959 investigative article in the Sunday supplement of a Denver, Colorado newspaper. This article reported that young people in a nearby city had been caught spreading plastic model glue on their palms, cupping their hands over their mouths, and inhaling the vapors to get high. Since then, the recreational use of various solvents by young people has occurred mostly as more localized fads. The ready availability and low price of these solvents make them attractive to children. Several of the solvents have been linked to kidney damage, brain damage, and peripheral nerve damage. And many of them produce irritation of the respiratory tract and result in severe headaches. However, several uses of various inhalants have simply suffocated. In recent use, uh, dust off abuse, diflurane has been implicated in numerous automobile accidents, many of them fatal. Laws to limit sales of these household solvents to minors or to make it illegal to use them to become intoxicated have been passed in some areas, but typically have little effect. And wrapping up this presentation is the GHB, which occurs naturally in the brain as well as in other parts of the body. Its structure is fairly close to that of the inhibitory neurotransmitter GABA. GHB has been known for some time to be a CNS depressant and has been used in other countries as an anesthetic. The behavioral effects are similar to alcohol, and higher doses produce muscular incoordination and slurring of speech. Publicity about deaths associated with the use of GHB and alcohol as a date rape combination led in 2000 to congressional action, directing that it be listed as a Schedule I controlled substance. But for reasons that are not well understood, GHT tends to reduce the frequency of cataplexy, which is one common symptom of narcolepsy.